Good evening, everyone, and welcome to our webinar this evening on living longer and feeling better with LVAD and transplant. Let's give it just a few more moments. We have some people coming in from the waiting room, and we'll get started here shortly. So welcome again, everyone. My name is Karen. I'm with the programs team at Mended Hearts. Thank you for joining us tonight for what will be a very informative session on living longer and feeling better with LVAD and transplant. A few housekeeping items before we get started. All attendees are in listen-only mode. Keep in mind, we will not be able to answer any specific questions related to your medical condition. Be sure to type your questions in the Q&A box so we can answer them at the end of our presentation. One of our esteemed volunteers, Glenn Kelly, will be helping to moderate the Q&A towards the end of the presentation. So thank you, Glenn, for helping us out tonight, and we'll see you in a little bit. The webinar is being recorded and will be available on the Mended Hearts Inc. website at www.mendedhearts.org and our YouTube channel. This webinar is part of our Empowered Transplant series and is sponsored by Abbott. So thank you, Abbott, for your dedication to the cardiac community. This shows some of the resources that Mended Hearts has available through our Empowered Transplant program. All of these are examples of discussion guides that take on different aspects of the heart transplant journey. They are available on our website at mendedhearts.org/empowertransplant. You'll find most of our educational webinars archived there as well as other discussion guides and resources. And you can also find a library of our webinars on our YouTube channel. And coming soon in the same programming, along with as part of Empowered Transplant, we have a couple of items that will be released soon. They include a discussion guide and a whiteboard animation. They will be available in the next couple of weeks, along with the other current resources that I spoke about earlier. And again, that website is mendedhearts.org/empowertransplant. And so join me in welcoming Dr. Farouk Sheikh. He is the medical director of the Advanced Heart Failure Program at MedStar Health Heart and Vascular Institute, the associate professor of medicine at Georgetown University School of Medicine. Dr. Sheikh trained at Columbia University and Johns Hopkins, where he later served as faculty. His clinical and research expertise focuses on advanced heart failure, LVAD therapy, and infiltrative cardiomyopathies. He has led multiple national clinical trials and founded MedStar's infiltrative cardiomyopathy program. Dr. Sheikh is widely published and recognized with numerous awards for research, innovation, and teaching. Welcome, Dr. Sheikh.
Thank you so much, Karen, and thank you to the Mended Hearts organization. So appreciative to be with colleagues and friends tonight that I'm going to meet for the first time, and I'm going to share my slides. Let's see. Hoping you can see my slides now.
There you go. Yes, we do.
Yeah,
Perfect. Excellent. Yep. So the topic of interest tonight and the title that has been chosen is to live longer, feel better with LVAD and transplant. And start with a provocative question to begin and for us to reflect on over the next 45 minutes or so. What would you do with an extra decade? Obviously, a somewhat tongue-in-cheek comment, but conceptually, the data we'll discuss and hopefully in the Q&A be able to answer some questions regarding the exceptionally exciting outcomes with the use of LVAD therapy, potentially in concert with transplantation and this concept of net prolongation of life. So we'll begin with some myth busters, discuss some myths associated with LVAD therapy, review the contemporary outcomes of this therapy, and then discuss the idea of improving longevity with a combination of LVAD therapy and transplantation. So myth number one, heart transplant survival is substantially higher than HeartMate 3 LVAD survival at 5 years. So just to review for those who may not be familiar, LVAD therapy, left ventricular assist device, is a FDA-approved technology that has been around for, in its current modern iteration, 20 years. And in the third generation of LVAD therapy, we are talking about a device known as the HeartMate 3, which, because of its structural features, has been shown to be a very durable device with markedly improving survival. And so I'm going to try to simplify this somewhat complex slide by drawing your attention to this area, the HeartMate 3, and what you see below it are the two predecessor or foundational devices. And what you see here, starting at time 0, when the LVAD is implanted, all the way to 5 years, is a remarkable improvement compared to the prior devices in the survival at 5 years with this technology. And obviously, it's very exciting news, and it's important for us to put it in the context of transplantation. So someone might say, given the longitudinal history of a transplant, well, how does LVAD therapy in this current era compare to transplant? And so heart transplant survival is amazing, outstanding. But when we look and compare it 5 years with an LVAD, the HeartMate 3, the current only FDA-approved treatment for advanced heart failure with an LVAD, it is actually very comparable to heart transplant, particularly when you incorporate risk factors that might unfortunately diminish the long-term survival for a transplant patient. So overall, 5-year survival is approaching 70%, but higher risk features, God forbid, things like diabetes, hypertension, or the need for a ventilator at the extended period of time at the time of the transplant, does lower the risk of long-term survival. So we are now approaching an era and a time where survival is starting to become more comparable. Additionally, we, as we would in any field, stratify the long-term survival based on a number of variables. And tonight we're going to talk about those variables, one of which is age. And survival in younger patients, which means a lot to me as I've recently celebrated my 50th birthday, now 51 years of age. I'm happy they still call us younger patients, is the concept that actually younger recipients of LVAD therapy in blue, so again, time 0 here on the left, going to number of years at the what we call the x-axis. And this blue line highlights that 5-year survival for individuals under the age of 50 is actually very much comparable to heart transplant, 73%. So we are now talking about a therapy whose long-term survival has improved. And as we'll talk about moving forward, the risk of adverse events, whether that, God forbid, is a stroke, a risk of a clot in the LVAD or the LVAD itself malfunctioning, are markedly reduced with this technology, which offers additional excitement for patients to stay out of hospital and to feel better with the therapy. You know, so often in our lives, we make decisions, or we think we are making decisions in isolation, but that is always not the case, right? There is always a trade-off. One decision and one action results in a reaction or some other unintended consequence. And shown here is this idea that choosing a heart transplant listing in favor of immediate stabilization with an LVAD can sometimes, unfortunately, have unintended consequences. There are, as you know, about 4,500 heart transplants available nationally per year, though we hope that that number will increase with novel, innovative strategies that are beyond the scope of tonight's discussion. But you remember, heart transplant, finite resource. LVAD, you know, not to say it's infinite, but it comes off a shelf and it is available for a number of patients. And when we wait around for a heart transplant, sadly, you know, waiting for someone deceased to pass and then being on a list with other people who are also in hope of a transplant, the risk is that your clinical situation could deteriorate during that waiting period. And that is uniquely higher risk, not surprisingly, for individuals who are older. So in yellow, the group that is 65 and older, in the number of years, many years ago, 2011, now to the current era, that risk remains significant, that people, while waiting for a heart transplant, can sadly die waiting for that. And that risk is higher than for younger people. So we must always remember that this is a difficult decision, that you have to have a close collaboration with your clinical partners, the ones that are advocating for you, your family members, your loved ones, to say, you know, how long is too long to wait? You know, if I'm getting sicker, should I not miss my window for engaging with a therapy that could really improve my quality of life moving forward? Myth number two is that, this idea that patients, and I've sort of given it away already, is that people under the age of 50 implanted with a HeartMate 3 have worse adverse events. So we've said survival is really good, but what about the events? Things that we don't want to happen, complications that could ruin or adversely affect our lives. Well, three variables in the LVAD space that have been, tried and true measures of success are things I think we would all agree with. We really want to avoid a stroke. We really want to avoid bleeding from the surgical event or down the road afterwards, and we don't want the device to malfunction. And when you consider these key three LVAD-related serious adverse events, we have never seen a device better suited to reduce this risk. Now, you might say 94% freedom from risk of a stroke. Well, that's not 100%. But remember, for heart failure patients, sadly, even without an LVAD, even without a transplant, there is some risk, a residual risk of a stroke. It's not 0%. And so this 94% is the best number ever achieved in the field based on, and this is not company data, this is actually our data, meaning a national registry where all centers, the majority of centers that implant LVADs enter their data for query and for scientific exploration to be able to understand how we're doing in the field. And that's known as the STS, or the Society of Thoracic Surgery Intermax registry, provides this data. And so for people under the age of 50, that number is exceptionally low. The freedom from bleeding, which was always been a huge challenge for us in this field, has also been reduced, and we're very excited about that. And device malfunction has also improved significantly as well. I'm sorry, apparently my computer wants to update something. Well, what about an adverse event? We want to be provide equipoise and provide a balanced approach. An area of opportunity that still exists in this field, so it's important for us to reflect on, is there is still a residual risk of infection. And we still are working in the field because of the driveline that connects the LVAD that sits under the sternum on the external portion of the heart, and requires electrical energy to be able to spin at thousands of times or revolutions per minute. That requires electricity. And so a driveline, as you know, or for those who may not know, extends from the abdomen. And that can, as for one variable amongst others, result in a risk of infection. And we're still working to reduce that risk over time, though some best practices have been identified, and we're working as a field to employ those characteristics. Myth number three, patients under 50 should be transplanted because we can always retransplant them if they have graft failure. The definition of graft failure means obviously that the heart that has been taken from the deceased and placed in the living, we refer to that as an allograft. And the idea is, of course, we believe, depending on various features, that the average or median survival, mean survival, is somewhere between 13 and 15 years with a heart transplant. And well, if you're 50 years old and that means gets you to 65, well, you'll get another transplant afterwards. We're hoping that will happen. But the reality is that within 20 years after heart transplant, your primary heart transplant, only 2.5%, think about that, 2.5 people out of 100 will receive a retransplant. Again, because there's thousands of people waiting for heart transplant. And even if you get a heart transplant, unfortunately, the outcomes are not equivalent to the first transplant. So there is risk related to retransplantation. This slide, which I think I'm very fond of, highlights patient-centered, multidisciplinary approach to therapy selection. There is no right answer. Heart transplant is an amazing therapy. It is because of heart transplant that I myself entered into the field of heart failure. But we now no longer have to make a decision competing between the two options. Both therapies are outstanding, and they promise to provide a marked improvement in the quality of life for our patients. But for some, based on characteristics like the need for multi-organ transplant, meaning you might need both a heart and a kidney transplant or a heart and liver transplant, it might be better to go directly to heart transplant. If you are somebody who has a bleeding predisposition, or you have a complex form of cardiomyopathy, or you have features that highlight your right ventricular performance is not normal, maybe also you have risk of a lot of arrhythmias, it may not be best for you to get a LVAD, but rather move towards transplantation. Now, what about an LVAD, a left ventricular assist device, as a BTT, or known as bridge to transplant, using it to get you safely to a heart transplant? Well, if you have high pressure in your lungs, known as pulmonary hypertension, that can be a problem. as our weight increases, unfortunately, the published data in transplantation says with a BMI or obesity measurement of greater than 35, some data above 30, the risk of complications with transplant increase. And for some select and increasing number of patients, the capacity to use the LVAD to actually allow the heart to recover, to improve with medical treatments is a real reality that allows the LVAD to be explanted and avoid the need for another advanced heart failure therapy. And then a very exciting area of development, this has touched me personally because my mother is in the midst of getting treatment for cancer, is the idea that you could use an LVAD if, God forbid, you had heart failure to treat a malignancy, get you through a period of significant risk, and then one day receive a heart transplant down the road. This is a concept that is being underutilized in our community, and we're working to implement it in a more standardized way for other patients. Device explantation for myocardial recovery requires some mention. And again, I know this is complex data, but let us just go through it. The idea is you were born with the heart you were born with. It's not working the way it should. It has failed, shall we say, for lack of a better word. So you need a device to improve your survival and your quality of life, and an LVAD goes in. And the idea that this LVAD working in concert with your heart muscle, because it unloads or takes the pressure off your heart, coupled with pharmacologic therapies, them, beta blockers, drugs like sacubitril, valsartan, SGLT2 inhibitors, MRAs, and some other strategies, including potentially device therapies, you might actually coerce or coax your heart into getting stronger. That allows the possibility of actually recovery. And this data, which comes from Intermax, again, that registry, and then a specific registry clinical trial known as Restage, which looked at the capacity of recovery, highlights there is a possibility of a marked difference depending on how aggressive we are with our drug therapies and other strategies to get as higher than 40% chance of explantation. Some of the features are highlighted here, which I won't belabor, but clearly in younger individuals, there is a possibility of recovery with an LVAD. Myth number 4, patients with various psychosocial risk factors have higher mortality than those without psychosocial risk factors. So what do we mean by that? Let's be empathetic and realize that, the world we live in is not, equitable to all. People are born from no fault of their own into difficult circumstances, and sometimes their family structure and their dynamics do not allow for a lot of social support. And in this setting, disease states like depression, anxiety can result because of the consequences of the life they live. And that may, require individuals to use, unfortunately, pharmacologic therapies, alcohol to treat those symptoms. And that might increase their psychosocial risk of bad things happening. And what this slide highlights is the LVAD can be a great equalizer. This data from the National Registry annual report in 2024 highlights that it doesn't matter your race. It doesn't matter your psychosocial status, your socioeconomic status. It doesn't matter how much social support you have, your ethnicity, and actually your sex. All the outcomes in the group that was studied in this population, younger patients under the age of 50, had equivalent survival. The numbers are the numbers, and I won't go through the statistical part, but just to say these numbers mean that when you compare the two, they are equal. And this is just exciting news. And here in DC, where we are very privileged in a safety net hospital to take care of individuals who are underrepresented populations, who don't have the same tools in their social support structure, we offer these therapies to those at extreme boundaries of both their personal health and their social support in hopes of being equitable to give everyone a chance for long-term survival. Myth number 5, making patients comfortable with palliative care is the best plan for individuals above the age of 75 who have advanced heart failure. And I had to include this in this discussion because it is really exciting news. This year's registry data, so that annual report I told you I just released in the past week, actually focused on individuals above the age of 65. But this data, which comes from that registry, national data on real people getting real therapies, not in a clinical trial, highlights that older patients defined above the age of 75 had a significantly lower rate of major complications such as stroke compared to prior generations with the current LVAD. And these elderly patients, of course, are not, unfortunately, because of the paucity of hearts available in the United States, able to get a heart transplant. Most centers will not consider over the age of 75, some as low as the age of 71, but you can still gain a tremendous benefit. And that's measured by us as the individual. So if I were a LVAD recipient, I would fill out a questionnaire related to quality of life. And I would say, here's my quality of life, 0 being the worst possible health imaginable, 100 being the best. And what you see is before you get an LVAD to 1 year afterwards, those numbers are heading towards a much higher number. The distance one walks is also a measure of our quality of life and our functional capacity, and that improves over time. So not only do you get a functional capacity improvement and a quality of life improvement, but as this most recent report shows, the survival has never been better for this cohort of patients. Very exciting news for patients across all the spectrum of age. Pause for 1 second while I clear my throat, sorry. Myth number 7, selection bias does not exist for women and minorities. I wish that were the case, but I think we all recognize that is unfortunately not the case. Despite the fact survival is equivalent, and in fact, in some studies, as shown here, numerically higher in women, women only make up 26% of patients in the National Registry and are underrepresented in clinical trials. The reasons that underlying this are unknown. There may be conception that an LVAD is too cumbersome or too large for a woman's body habitus. The data clearly highlights that's not the case. In fact, this LVAD is implanted in pediatric patients with great outcomes. And so we really must work and identify, as we have in other areas of medicine, not just cardiovascular medicine, but other aspects, how we equitably share this therapy with as many people as possible. Additionally, when we stratify patients on the basis of their self-described race, as is shown here, Black patients, white patients, it didn't matter. Other survival was equitable and equivalent, statistically, shall we say, for those individuals under the age of 50. And sadly, for reasons that also are unclear, people of self-described Black background are less likely to receive LVAD therapy despite the outcomes that are garnered in the National Registry, for reasons, again, that we must explore and we must work to make more equitable. Ethnicity here, it just highlights what we were saying about Hispanic versus non-Hispanic populations or Latinx populations, demonstrating that that cannot be a criteria by which we do not offer these treatments. Again, a great equalizer. Let's talk briefly about real-world experiences, then we'll get into this concept of net prolongation of life and the possibility of living a longer, more productive life. Just briefly, we've highlighted survival is incredible. Again, I'm going to draw your eyes to this blue number here, 73%. If you're under the age of 50, 5-year survival is now comparable to those who receive heart transplantation. And this idea, again, that potentially its extension of life with great quality of life might provide benefit will be explored over the next few slides. Additionally, as I've highlighted before, the idea that we need to worry about this population versus another, I'm belaboring this just to say this data does not support that. The therapy can be beneficial to all, and we should not use criteria as psychosocial status or social support as a limitation, because the data no longer supports that. This device is so durable. I would remind you that the journey LVAD therapy is on is like a pacemaker. Pacemaker recipients are not asked about their social support. They're not asked about all their psychosocial status. I'm not saying we're there yet in this technology, but that journey is clearly underway. And when we think about the foundational first 2-generation devices compared to where we are today, it's amazing the progress that has been made and the quality of life that can be garnered for these patients. So this summary has been highlighted. I want to draw your attention to this bottom left corner. The idea that we could potentially, instead of starting with a heart transplant as the gold standard, improving the quality of life for patients, recognizing the limitations in terms of the longevity of a heart transplant as terms of its graft function and how long it might support a patient with a good quality of life. Could we conceptualize the idea that an LVAD would be the first therapy for a patient, would be used to bridge a patient successfully with a great quality of life and functional capacity to a heart transplant, which would extend the life of a patient, conceptually known as an idea of net prolongation of life. Now, let's be fair and balanced and say these are conceptual ideas. They have to be tested in a meaningful way, though data is emerging to support this concept. But let us focus now on this idea of net prolongation of life, improving longevity with LVAD and transplant. And given the outstanding outcomes that you've now seen over the past 20 plus minutes, the idea that we might be able to do this with the combination of therapies. So again, net prolongation of life refers to the strategy of implanting an LVAD in a younger heart failure patient with the goal of extending their overall survival by delaying a heart transplant, either temporarily or long-term. Again, the idea long-term is one that your quality of life is really good with an LVAD. Maybe you're not ready emotionally or physically to go through another surgery, or that we might actually be able to recover cardiac performance to be able to actually deactivate and decommission the LVAD, and you go back to your native heart function without needing an advanced heart failure therapy. So an advanced heart failure patient who is eligible for heart transplant gets a heart transplant and they move on with their life, recognizing that if we take that same patient, potentially with the incredible outcomes that we've just highlighted, use an LVAD to improve the quality of life, get patient out of harm's way, go back to their functional capacity gain and quality of life that is their self-measured quality of life, and delay the heart transplant, we may potentially improve the longevity of the patient's life. It's important to understand that 5-year survival for heart transplant is 75%. I've highlighted that before. It has improved from generation 1, which is the older population, 1982 to 1991 heart transplant recipients, to the most recent, which is 2009 to 2016. But again, unfortunately, it's not 100% survival. And there are challenges: immunosuppressive therapy, the risk of infection, the risk of malignancy, complications such as cardiac allograft vasculopathy. So it does come with its own set of challenges. We wish that either of these therapies were true cures, but they each have their own set of challenges that must be acknowledged and respected so that we have a balanced and an equipoise in regard to how we apply the therapies. Remember, shared decision-making and informed consent regarding these therapies is required, where we put you, and in service to you as clinicians, we place the data in your hands in a balanced way so that you can understand what is the best therapy for you. So how long does a heart transplant last? Here's data that I've already highlighted in the generations, where current data from the penultimate era, 2002 to 2008, says the median, that's the middle number, not the average number, but the middle number, is in all patients about 12 years. In the most recent era, it looks like that data is going to be a little bit better. We're still waiting for some more information, but again, the need for a retransplantation, the likelihood of that is unfortunately less than 5%, as shown here, 2.6%. And the outcomes are not quite as good. So we do not deny transplantation is a gift of life. We do not deny transplant is a gold standard therapy, but unfortunately it is with its own set of challenges. And so we must be cognizant of that and acknowledge that as we consider these therapies. Is heart transplant the best option for a younger patient? Now, if you had asked me many years ago when I was an intern, a first-year doctor at Columbia in the early 2000s, it would have been a no-brainer. No doubt, still heart transplant's better. But now, with a more robust LVAD and a more robust understanding of how we manage patients with an LVAD to improve their outcomes, we are learning that it is actually possible to revisit that topic. And for younger patients, heart transplant may not be the first option, because of this reality of time and how long the middle number will be in terms of transplant, right? So for younger people, you might expect an average survival of 13 years with that heart transplant, but that won't get you to a normal lifespan. Is there a way with the current LVAD therapy that we could extend your life, give you a better quality of life, try to recover your heart function? If that does not work, then eventually through shared decision-making, try to get you on the list and get you to a heart transplant, which could extend your total or the totality of your life in terms of number of years. An LVAD implant may result in the net prolongation of life because of this concept that the long-term survival at 5 years is now comparable to heart transplant. And so if you imagine, okay, I'm going to take the risk of 2 surgeries, meaning an LVAD and then a transplant. I'm going to accept what the published data says, not what Dr. Sheikh says. This is data, and as somebody who has a scientific background, someone might accuse me of, wow, he's really going into the weeds with all this data. I just want to highlight the number. It's just a number, but that it means that this is similar, comparable to heart transplant, that I'm going to take a similar risk and consider extending my life for those years to then potentially get heart transplant on the other end of those years of the HeartMate 3, so as to improve my long-term survival. I'm going to skip this because it's a repeat. we talked about the median survival in heart transplant, but we haven't actually talked about the median survival in LVAD therapy. And actually, I was just telling the Mended Heart leadership that this most recent registry data that I mentioned just got published about older patients. There's some data now that patients' median survival with an LVAD is now actually 7 years, meaning more than 50% of people are alive at 7 years. And this data, again, it has to be proven. This is just still estimates. But if you looked at survival, now we said at 5 years, 73%, and we just extended that curve, statistically out to 10 years, it might be that a LVAD recipient has who's under the age of 50 might have a 10-year survival as the middle number. That's incredible. So that potentially is where we come up with this idea in the first provocative slide. What would you do with an extra decade? What could potentially be gained by that reality? And I think that is something certainly worth discussing, having a balanced approach in how we consider these therapies. So, the other aspect, which I have highlighted, is this idea of recovery. The International VAD-Wean Registry, which is an incredible registry, which we here at MedStar are very lucky to contribute to, has been led by the University of Utah and Montefiore, Albert Einstein, and really all these programs around the world. Highlights shown here that basically for those patients who have an LVAD, who have recovery and are successfully taken off of an LVAD, which we say weaned off the LVAD, when you compare their long-term survival, these two curves are running on top of each other. So that means they are, statistically equivalent. There is no difference. And this was, again, in a propensity matched cohort, meaning they took variables of the patients, made sure the groups were similar in those variables. And then the only thing different was a heart transplant, post-heart transplant survival versus being weaned off an LVAD. And after a number of years, the survival was equivalent. So again, the possibility of survival to increase and improve your quality of life is a real thing and should be considered in this calculation. So what would you do with that extra decade? More life means more time to live, obviously. And I can't wait to hear what people have to say in regard to this. For young people, we have a heart transplant. We know the median survival, again, somewhere around 12 years, maybe a little longer. Retransplant, unfortunately, very few people will get there, just given the lack of organs. And conceptually, another possibility is this idea of getting an LVAD, improving survival, potentially. We certainly know it's 73% at 5 years. It may be that the average survival, the middle number, the median survival is over a decade. We could gain that extra decade. And so something that we must consider as we now enter in this new era of robust LVAD support with HeartMate 3. And in certain patients, cardiac recovery is possible, as we just highlighted. So you might actually be able to explant or remove the LVAD and just live on your own heart, as we showed you in the preceding slide, conceptually the idea of being weaned off your LVAD with myocardial recovery. And so how can we fit that prolongation into life, into a bigger picture for heart failure management? We've just shown this concept. Let us think more broadly in the idea of recovery, and let us also think about the reality we want to avoid advanced heart failure therapy. So we want to think about the idea of making sure we use neurohormonal antagonist treatments, again, beta blockers, sacubitril valsartan, SGLT2 inhibitors, MRAs, maybe using those therapies, using devices that can work in concert with the medical therapy to really gauge how are we doing, these implanted pulmonary artery sensors, to avoid the advanced heart failure phenotype. And that is something that conceptually, where nearly 7 million Americans now have heart failure, is something we're working towards to improve the quality of all of the lives of our patients. And so with that, I will stop sharing my slides, and we'll use our time to answer questions. Thank you.
Great. Farouk, thank you. Wonderful presentation. There was really deep in there, so I hope folks buckled in and came along, but there were some super takeaways, and we'll probably touch on those. I want to invite people with questions. Please select the Q&A at the bottom of your screen if you would. I'm going to try to find a couple of those that were in the comments. There's been an active conversation going, and that's an easy way for questions to get buried. So if you do have a question, go ahead and answer with the Q&A. There was, I'm going to lead off one that's an interesting one that was posted out there, and that is, okay, let's say you've already had a heart transplant. Let's say that you're, 10 years down the road. Pick your favorite year, whatever. Have you had any patients, and is it possible that a patient may need a LVAD who had previously had a heart transplant?
So an LVAD with placed in a heart transplant recipient.
Transplant heart, yeah, somebody who
Yeah.
had a
So
transplant.
that's been described. Conceptually, it's a failing heart, right? So the idea, the phenotype is that the heart is no longer capable of doing what needs to be done. There are challenges, and it hasn't been studied rigorously, Glenn, because heart transplant hearts, when they fail, they typically don't enlarge. And remember, an LVAD is best served in a heart that has over time enlarged, because of when the heart gets weak, its capacity of generating force for blood flow to move diminishes, and so the heart has a natural or unnatural capacity of enlarging to deal with and receive more blood. In heart transplant recipients, typically the heart actually remains a normal size, and so implanting an LVAD in that structure makes it more challenging, as has been the case. We had that slide that compared features that might favor if someone to get a heart transplant versus an LVAD. One of them is the structure of the heart. We talked about restrictive cardiomyopathy, which is the idea that the pumping chambers of the heart are normal in size. And that has historically been a barrier to the use of an LVAD in a heart transplant recipient. Not saying that it's not possible, but also remember that our heart transplant recipients do require immunosuppressive therapy to protect them from rejection. So the concept of infection and with an LVAD is increased, at least theoretically, in this scenario. And so it's one that has not historically been used frequently, but it has been described.
Yeah, thank you. Thanks. So I'm going to throw a future one out there for you to spice it up as we go through here, and that is, what's the future of, say, a wireless LVAD or a wireless VAD?
Yeah, appreciate that. So a device that requires no drive line, fully implantable, requires obviously a form of electrical energy, and many companies are working to identify ways to do this. I think we've learned a lot because of probably electric cars about energy and the transfer of energy and how we do that. And the human body, it's tough. It's conceptually difficult. How can you generate enough energy for a long period of time to run a machine like this that's durable and that allows someone to have a reasonable quality of life? I don't have, unfortunately, a timetable for it, except to say many people and many organizations, many industry partners are working on it, including Abbott. And we're clearly still a number of years away from this. Now, there are other types of mechanical devices being generated and designed that have features that may obviate the need of the traditional driveline. So we've got to keep our fingers crossed and stay tuned for future Mended Heart meetings and presentations, because you might actually have some of the industry partners present some of that data, so they know, we know where we are in regard to that development. Unfortunately, I wish I had a timeline, except that continued evolution and innovation in electrical transfer across the skin, coupled with a battery life generation and the use of a machine with less electrical power need, are where the features that need to be worked on, and we continue in the field to work on it.
Great, great. Okay, so there's a couple of questions in here, and I'm going to kind of paraphrase in this. So this concept, which I'll say in the medical world, is called net life prolongation. And we're talking about this. Okay, so basically extending life so you can live better, live longer, etc. Okay, if you had to put what's the age range for this baby? Like if you had a patient, and I guess you could assign all these other additional qualifiers or symptoms, etc. But what do you really think is the age range to get this kind of bounce that we've kind of been talking about?
Well, conceptually, based on, again, the data we shared this evening, really like that number under 50, right? So again, broadly speaking, because we now have data really extending beyond 5 years with the HeartMate 3, the LVAD, that gives patients real reassurance that the risks day to day, month to month are quite low with the HeartMate 3, and one can gain a really great quality of life with the therapy. Those years gained with a high quality of life, again, we're not saying they're perfect. We recognize there are challenges, but I think so often historically in our field, we did use transplant as this mythical sort of existence and structure that's the gift of life and it's a cure. But the reality is, as many people on this in this webinar know, there are challenges with heart transplant as well. And so the idea is that you take the LVAD, gain these years of quality of life, and then consider transplantation, where again, incredible quality of life, wonderful things, but despite our innovation, despite the incredible strategies to manage patients with a heart transplant, we're still stuck with the reality that the median survival is, again, somewhere, depending on the features of the individual, 12 to 15 years, right? And so when we're talking about, hoping for people to survive, like most, expected survival for men and women into their 70s and beyond, the reality is you do the math on that and it becomes challenging. And, there's been sort of a falsehood that, well, you can get another heart transplant, when the reality is that's just, as we see, that is a very infrequent reality. It's not likely one to increase anytime soon because the number of people who need a heart transplant is so high that it's conceptually hard to imagine. And so under 50, imagine 5, 8, 9 years on an LVAD, whatever that number is, those years are extended with great quality of life, which then gets you to get to a heart transplant where, listen, there are risks with an LVAD and getting a heart transplant, the surgical risk, a repeat surgery. But the data has increasingly demonstrated that those risks are not as high as we once foresaw. If you look at registry data, and by that I mean large data on large populations of individuals, it's actually quite favorable. And so I still stick with that number under 50, recognizing that value might increase more the younger you get. Sadly, we take care of patients in their 20s, even younger patients, where the device can really extend life and provide good quality of life. Again, that number is also very individualized, Glenn. So every individual has to, look at the therapy. There are other aspects. I hear from younger patients about the cosmetics of LVAD, or this is I can't swim or something like that. These are very personal decisions. But when taken in totality, particularly a center like ours, where many of our LVAD recipients who were younger, they had challenges in their personal life in regards to, they might have been obesity, it might have been uncontrolled diabetes, it might have been other, psychosocial challenges they were working on, alcohol dependence, etc. We were able to use the therapies to help in an empathetic way, get them through those challenges, and then offer them transplant afterwards. It also helps people regain a quality of life to get them back into society in a meaningful way. So the variables are very individually based, but the answer, I think, still remains around that 50-year age because of, again, what can be expected with a heart transplant subsequently.
Yeah, I'm going to offer kind of thank you for that. Along the lines you were talking there is activity level, and there's a question in the Q&A about activity level, and it's can you offer just the kind of a perspective on I'll say the external battery conundrum, driveline conundrum, etc. for folks that want to play golf, play pickleball, etc. And I will make one comment. I have a dear friend who is, I think his handicap's about a 10, and with an LVAD. We just LVAD improved his handicap. So he's quite but anyway, go ahead.
Yeah, no, I appreciate the question. It's a really important one, and yeah, I'm sorry, I'm not staring off into space. I'm just reflecting on so many people's memories of treating patients and just such fond experience of the journey that my career, as just one individual in this field, has been on. When we started with earlier generation LVAD therapy, we thought you couldn't do this, you couldn't do that, and I have the patient who needed an LVAD, wasn't at the time when we met him eligible for transplant, and he was a mover. He lifted heavy equipment. I mean, we're talking about dressers and sofas, and he was like, "This is my business. I have to do this." And we didn't know what to say, because we hadn't really seen it. And so he pushed the technology. He taught us what was possible. He figured out how to manage his drive line,
Mhm.
and eventually got to the additional treatment, a heart transplant.
Mhm.
Patients who wanted to exercise, bicycle, forms of other athletic endeavors. Golfing is a great example, and they push themselves. They challenge themselves. The other one that I conceptually always heard was, "Oh, you can't travel, you can't get on a plane, you can't travel." And we had an elderly couple, husband, wife. The husband was the recipient. He loved to travel. He said, retirement was about going to Europe. We planned all this stuff. Can I do it? And we said, yeah. And connecting with partners transcontinentally. One of the coolest aspects of our lives was to connect this not so big community, meaning you can connect with anyone around the country, around the world, and helping people achieve their goals. I gave you a long-winded answer to say, yes, a barrier is electrical energy prevents the swimming and the submersion in water. We recognize that. But I would also submit to you and to the audience, there are some exceptionally novel tools that are being developed by our industry partners to allow longer time on batteries, which I think the quality of life there is excellent. Smaller batteries in terms of their silhouette, their caliber, so they're not as cumbersome, and even strategies to potentially disconnect from the controller, so as to allow you to be on batteries, but not tethered in the way that we once were, where you have the batteries um, uh, and all the accoutrements that are weigh you down. There are times people walk into our clinic now dressed in their work garb. You'd be challenged to know that they have an LVAD. And so my encouragement to anybody who's has friends or family or people who are thinking about the technology or in the face of these challenges, to your best way to do this is become an educated consumer and reach out to your local partners, meet patients who have the technology, because there is a lot of innovation that is coming down the pike in regard to how to make this more feasible, and to also give patients quality of life when they can be on technologies mobile without having to be stuck or feeling like they're being encumbered by the drive line and the controller.
Yeah, great. Thank you. Thank you. Harry, you got several questions. I'm going to try to knock out a couple of these.
Sure.
And that is, okay, so let's use 1 year survival numbers, LVAD to transplant. Do you recall differences off the top of your head?
Yeah, I mean, they're again, not, and this is a disclaimer, but an important one that could have been stated even at the time. We are, unless we do a true clinical trial where we randomize patients to an LVAD versus a transplant, we always have to take this data with a grain of salt. But that being said, 1, 2, 3 year survival in selected populations, they are comparable. They have become comparable, numerically similar. Above 90% in 1 year is a number that gets thrown out a lot. Remember, again, it depends on the individual patient's characteristics as to what that number looks like, but they are now very comparable. 5 years, again, as I think I belabored it with the slides, but under 50 years of age, it's the median survival, or the expected survival is over 70%, which is in range with heart transplantation.
Great, great. So let's talk about age for a moment. This is outside of the net life prolongation, although it's going to extend someone's life. Um, we know there's no hard top age for transplant, right? Some centers at 70. I know there's some in the comments here, 71, etc. LVAD.
75, some centers are 75. Yeah.
Okay, gotcha. Good. What's the oldest LVAD you've heard?
I don't, there have been reports of people well into their 80s, and I may be wrong on this. There might have even been someone older than that. In our center, we have certainly had a patient, and multiple patients. I should probably know this answer, but it clearly a number of patients over the age of 80. We are approaching the 90th birthday of one of our LVAD recipients, and I'm looking forward to celebrating that as he approaches his 90th birthday. Yes, I too was shocked by it, no pun intended. Encourage everybody to explore the most recent STS Intermax report. Again, it's scientific, but any one of your clinicians can demystify it. But the idea is And the reality is with this technology in an older patient population, survival is excellent and has improved akin. I'm not saying they're equivalent, but akin in terms of the gains, the net gains that have been made for young people with this LVAD. There are similar gains being made for elderly patients, which affords a new huge opportunity for a number of patients to receive a therapy that otherwise was not possible with earlier generation technology.
Great, great. I'm going to extrapolate a question Keith had here. Let's talk about pulmonary hypertension for a second. And that is, let's say, pharmaceutical therapy. So taking medication versus an intervention like transplant or VAD. Is the threshold, and it's just a very let's generic it, right? So patient has pulmonary hypertension, they're going to need a more advanced therapy. Is the any advantage to transplant versus VAD? Like they could stay on medication longer with one versus another? Because that's the easiest way to cut through that.
Yeah, let me digress just slightly to say, just
Sure.
to make sure everyone's on the right, frames, coming from the same perspective, is the idea that pulmonary hypertension, high blood pressure in the artery feeding blood to the lungs, is a contraindication for transplantation in isolation because the new heart that's implanted into that environment, typically the right side of the heart fails. And again, there are specific metrics, specific numbers that your individual transplant centers will work with you to discuss. What has been demonstrated in a number of patients is the use of an LVAD can help the blood vessel remodel. In other words, lower over time the pressure in the artery of the lungs, either in isolation, just the act of putting the LVAD in, or in concert, Glenn, with pharmacologic therapies that to help lower that pressure. And we've certainly at our center done this as a strategy a number of times to great effect. Can't promise it's going to happen. Unfortunately, I wish we could, but there are predictors as to those who can. And so idea is that lowers the risk of an adverse event with heart transplant, again, with good quality of life. Pulmonary hypertension in and of itself is not a contraindication for LVAD therapy. Again, beyond the scope of today's discussion, not to get, I'm already being accused appropriately of too much medical jargon, so I'm going to avoid that. Except simply to say that remember, we need a very competent right side of the heart to support the LVAD. That when patients have generated those pressures, that usually, again, there can be exceptions, but they usually suggest that the right side of the heart is pretty strong because it's been dealing with this high pressure. And so LVAD therapy, again, caveats all around, usually is able to support patients to allow them then to allow the unloading features of the LVAD to help remodel that blood vessel while simultaneously strategies pharmacologically, as you highlighted, to help bring those pressures down. And so one size does not fit all. It requires collaboration with your heart failure specialist, pulmonary hypertension expert. And so it's a team effort. And I think that was highlighted in some of the slides regarding multidisciplinary decision making, how we decide on this.
Yeah, great. Thank you for your answer. Couple of questions, and I'm going to generalize these then on behalf of Sam. And that is, let's think implantable devices vis-a-vis a pacemaker, an ICD, in combination with an LVAD. I know the answer. I know some people on some patients, but go ahead and answer that if you would.
Yeah, appreciate that.
Yeah.
There is nothing unique about LVAD therapy that makes it incompatible with other therapies that you've described. In fact, probably depending on the center, somewhere between 60 and 70% of patients have a pacemaker or defibrillator preceding their LVAD, right? It was already implanted. That in and of itself does not prevent someone getting an LVAD. There are other therapies upstream, meaning earlier in the disease state, that patients receive with heart failure that can work in concert with an LVAD. There are things that reduce the burden of mitral regurgitation or leakiness of the valve, one of the valves on the left side of the heart called a mitral clip, or other technologies that can be used. Other devices that are implanted to improve the performance of the heart and the quality of life of patients. You're going to review these things with your doctors. I think the one thing that we are mindful of, doesn't mean you can't get an LVAD. Mechanical devices, mechanical valves on the left side of the heart, meaning the mitral or the aortic valve, your surgical team needs to review that and then decide whether that is reasonable with an LVAD. Doesn't mean, again, you can't get an LVAD. It just means that you might have to have your valve replaced at the time of the surgery, and then the risks have to be considered as to how much additional risk that creates. But really, our patients are benefiting from multiple strategies of device intervention to improve their survival, their quality of life, their functional capacity, and just have to engage in conversations with your local partners to figure that out. LVAD therapy and those therapies do not make it a contraindication. You don't have to decide, oh, I've got to get an LVAD because I can't get a pacemaker. That doesn't exist. These strategies are compatible with an LVAD.
Yeah, great. Thank you. There's been, I'm going to just make a comment. There's a couple of, I'll say, questions about their one's personal health or personal situation, and as we have the disclaimers up front, we can't go into personal individual cases. Okay, so refer you back to your medical team where you live to kind of ask those questions.
Yeah.
And so forth. But that said, we've got time for probably one or two others that I'll hit on.
Sure.
And that is, let's see, where are we at? I'm trying to look for one that's, this is going to be a hard one to answer, but I've seen it from a couple of different folks in couple of different ways. And that is, people describe symptoms that mean class 4 heart failure. Okay, so the very advanced heart failure, maybe they're on maybe they're on an inotrope like dibutramine, maybe they're on other pressors, maybe they're, et cetera. Advanced pharmacological therapies as we described. What if somebody's like, I don't want somebody cutting on me, that's it. I'm going to take this as long as I can, and then I've lived a long life, and they're only 60 years old. Okay. You've had to see patients like this, I assume. What kind of words do you offer in those situations?
It's such an important question.
Yeah.
I'm grounded in the reality that one of the reasons I became a physician was conceptually the idea of believing in the, developing the knowledge base to be able to connect with other human beings to serve them. And I mean that in the highest possible way, in service of an individual. Is a great gift, and by that have to imagine and really understand the concept of empathy. Right? What is it like to sit in someone else's skin? If I'm sitting across the bed, the patient is in the bed or in the chair, and I'm with them. What would it be like if I were in that position? What were the things that I want to know? Conceptually, our responsibility to each other is to be forthright, to try to be as close to unbiased as possible, recognizing none of us are perfect. We may have our own personal, preconceived ideas about what we would want. But the key is, it's not about what Dr. Sheikh wants or what Glenn wants. It's about what the individual wants. And I think if we engage in a conversation through the concept of shared decision-making, we provide patients the tools to understand what therapies they can employ, what those risks are, what the benefits are, what the alternatives are. And after totality of the information, and we believe patients have been able to absorb that information, they're able to understand it in a meaningful way, patients decide to choose something like inotropic therapy, so be it. We will support them. The journey I've been on with patients I take care of is to support them irrespective of the decision. What we know about inotropes, Glenn, unfortunately, that's where the LVAD field in its modern iteration begins in 2001, right? The REMATCH trial asked the question, can a mechanical device made to be implanted in human beings improve the survival compared to just the standard treatment? And the answer is clear. I still remember the curves, because it's probably one of the major reasons I became an advanced heart failure doctor, is we realized for the first time in that randomized study called REMATCH that if you got a device, an LVAD, you were more likely to live longer at 2 years than those people who are on inotropic therapy. And, unfortunately, inotropic therapy, and there are, like any statistical idea, there's a bell-shaped curve. Some people are on the far end of one spectrum, unfortunately, on the other end of the spectrum. But the average, the median, the mean or median survival is 6 months with an inotrope. And that obviously is far shorter than an LVAD, recognizing, again, personal decision. Some people have spiritual reasons why they don't want surgery. Some have, unfortunately, memories of loved ones having bad outcomes with various therapies. My advice would just simply be engage with colleagues, engage with healthcare experts, and make sure that shared decision making is employed, because I think that's the best way we can, in service to our patients, give them the tools necessary to succeed as they define it.
Thank you. What a great answer that summarizes not just that question, but the approach to our entire hour.
Appreciate that.
I very much appreciate the time you've invested with us. I appreciate the time that everyone's invested in this webinar. Tell your friends, tell your family. It'll be up on YouTube tomorrow. And then we have complimentary resources such as a discussion guide. In fact, there's the draft, which will be up on the website here in a couple of weeks, as well as a whiteboard animation, about a 3-minute video that'll walk you through the concepts that Dr. Sheik has discussed here. So thank you all again, and have a wonderful evening.
Thank you so much for the invitation.
Mm-hmm.